By now, after the end of the treatment of early HCC, we are going to have the vision of treatment of late HCC, and it's our pleasure and my pleasure to introduce Professor Dr. Ghassan Abou-Alfa from Sloan, Kettering, New York. He's one of the big names and authority in the field of hepatocellular carcinoma. He will address an important subject, the treatment of late stage of HCC. And he's one of the pillars in the process of African guidelines for HCC. Ghassan, please join.
Morning to you, Ashraf, and thank you so much, Dr. Omar. Thanks so much, Dr. Roberts, for this incredible meeting. And of course, a great thanks to AASLD and COLDA for the opportunity. Wish I was with you in person in Cape Town, but at least very good morning to you all from New York. I'll go ahead and share my screen and we'll carry on as nicely Dr. Omar introduced the next subject, which is the advanced hepatocellular carcinoma. So no doubt that it was a great prelude and a great introduction by Dr. Omar to talk about the guidelines for Africa that proudly we are all doing together. And I'm going to definitely present this within the context of the presentation today. These are my disclosures. And this is my contact. Please feel free to either take a picture of the QR code or copy what you like. And of course, COLDA team has all those details. If you wish to connect with me, I'm more than happy at any time to answer to any questions that could be of help for further collaboration that we can all do together. So with this said, we're going to just touch on the agenda. We'll give some background data to why we're doing all of this all together. It's definitely understood by all of us the important purpose of what we're doing together. How to build the African continental HCC guidelines, what generated data we have so far, and where do we go from there? What's the next step? So in regard to the background, I mean, no doubt that realistically, we have a big challenge in front of us. As we can see here from Dr. Zhonggang, well-known and seminal paper back in 2019, showing the comparative median survival of patients with hepatocellular carcinoma worldwide. And we are many steps away where Taiwan does not even have a reachable median survival, while in Africa we're still on the average, and to be fair, other certain areas will do better than others, but nonetheless on the average we're talking about 3 months. So no doubt we have a very big task that our dear patients in the continent of Africa entrusted us on, and we need to do it. So one might wonder, like, why do we need to look into guidelines for Africa? Well, the data came out from the kind of, the whole exercise that we did together. I'm going to go over the exercise in a second in detail, but just give you a little bit of sense about what are we talking about here. I want you to imagine about close to 500 healthcare workers, mainly, of course, physicians, from 3 regions that we decided to divide as such: North and South, East and West, and Central Africa. We're given a questionnaire to really answer, like, what do you use? What do you have access to? What do you trust in regard to guidelines? And shockingly and surprisingly, you can see that the data showing that it's all over the place. And as much as every one of those guidelines authority felt and believed that, after all, we have what really the continent of Africa would require, sadly, the reality on the ground is totally different. For example, we know that there is a revised, excellent and well-done guidelines for NCCN for Africa. And as you can see, at best, it's not really recognized or used or identified to be the appropriate reference in the continent of Africa, except by 30% of the physicians. Maybe a tad better in regard to EASL, and this is something very important to see how the European efforts were understandably more pertinent and present in Africa. And then you can see then we have a little bit of a trending towards other guidelines, among which the AASLD. And in addition to that, there's an important and fascinating effort that some of our colleagues in Africa realized that, you know what, after all, we don't have our own, we don't have guidelines that might work. Let's develop our own. And this is really especially pertinent in East and West Africa. And of course, there is some that where guidelines are not used because simply we don't have the access, we don't have the support, and as such, we kind of like don't depend on specific guidelines per se. So again, this is one more time a very important awakening in regard to the challenge per se. So let's go a little bit of detail about how did we get to that, to those data and provide more data as well. So in regard to the African continental HCC guidelines, I really have to start the story from where it started. And Dr. Omar and I, we were actually sitting together in Chicago during the AASLD meeting, and we reflected on, I correct myself, during the ELCA meeting, and we reflected on, after all, we need guidelines for the continent of Africa, written by Africa for Africa per se. So we went on this big task, and we end up with a very proudly a great committee that we are all part of. And I would like to truly read the name of everybody because to identify, because of their great effort that has been running already for years. So of course, Dr. Omar, myself, we co-chair that effort, and we're very proud of where we got us to. And with us, there was really a great representation from every corner in Africa. As you can see, we have Dr. Afihene, who really has been great leader and great connect to other colleagues all over Africa from Ghana. Dr. Agi Nkansa from Ghana as well. Dr. Altisi from Nigeria. Dr. Asselbang from the US, but of course, originally from Zambia. Dr. Balogun from the US, but originally from Nigeria. Dr. Buguma from Burkina Faso. Dr. Bounajar from Algeria. Dr. Kunha from Mozambique, who really has been also a great contributor and connecting to other colleagues. Dr. De Angelis, our CMO, who really sponsored and supported the effort and was there to give the opening ceremony discussion. From Egypt, Dr. Servé Albert from Cameroon, Dr. Jonas from South Africa. Hello, Edward, and great being in town today. Dr. Peter Kingdom from the US, Dr. Kurumbukus from Mauritius, and also Dr. Conan Haile Mikhail continue to kind of like, you know, be celebrated everywhere from Ethiopia. Dr. Musa Ali from Chad, Dr. Ndlovu and Gozo from Zimbabwe, great effort as well. As well as from Ghana and Nigeria, correction, and Dr. Soram from South Africa, Dr. Spearman from South Africa, and good to see both of you and proudly. And last but not least, Dr. Christian Zoton from Cameroon, and of course, Dr. Zhudong Yang from the US in regard to connectivity with the work in Africa. Thank you. So what did we do? We actually built in the program, and it was set to be presented and delivered exactly a year ago, like in October 2020. Or any payments. This was fully supported by Sloan Kettering, and we thank our sponsors of this study, of the effort per se. And we simply asked everybody to answer simply a set of questions about, you know, their specialty, how how they look into the staging criteria, at the same time guidelines in regard to resectable disease, locally advanced disease, and of course advanced disease, and at the same time what do you use in all those different lines of therapy. We got an ample amount of data that I'm going to show you. And if anything, the effort, just to give you a little bit of setup how it happened, on the 2 days, we pretty much had 4 sessions. The first one was regard to prevention and vaccination. And as you can see here, we looked into HBV, HCV, and NASH. And of course, also in regard to the prevention vaccination, we had discussion after presenting the lectures that were led by Dr. Roberts, Dr. Omar, and Dr. Suram, and then Dr. Yang presented on the discussion. When it came to the regions, why did we decide in that way? This was done by the group, like, all those colleagues together. We elected that we'll divide the continent into 3 regions based on GDP. Could it be perfectly right? Not necessarily. Could it be fine-tuned further? Of course it can, but it really, for the practicality purposes, we decided on that component of north, south, east, west, and central. And here we go. For every one of the sessions, we had the diagnosis and staging, we have the therapies, we had an open forum discussion, and of course we had a great interaction with everybody per se. Dr. Spearman did the diagnosis, Dr. Bunichar did the therapies, and Dr. Ndlovu did the open discussion for North and South. For East and West, it was Dr. Desilgan and Dr. Ndulumbu, and at the same time, Dr. Afiheni did the open discussion. And ultimately for Central, Dr. Omar started the day, and then Dr. Soton did diagnosis, Dr. Makondi did therapies, and Dr. Asombang did the open discussion. So what did we find? And this is really the key element here. This, as we just saw it from Dr. Omar, this is our proudly presentation at Aortic, and the manuscript is actually ongoing. And many of you know, for those who are involved in this meeting, we have another meeting coming up in a few weeks to finalize all those efforts and move towards the publication. Very important that we do recognize that we proudly did great effort, but to be fair, not necessarily full. As an example, and there's only an example, we were proud that of the 14 countries that represent Central Africa, we were able to reach to data from 8 of them. But of course, we'd like to get data from everybody. And this is really the next level of our efforts to really ensure that we reach everybody with whatever access they heard and did not hear about what we're doing. I like to give the credit here to all colleagues, and especially here I mentioned Dr. Tsoto from Cameroon, because if anything, we wanted to make sure that really we hear the real stories. We didn't want to say like, oh yeah, the great efforts is to show that the best treatment is for advanced HCC is atezolizumab plus bevacizumab. This is not the point. The point is, what am I doing on the ground? What's accessible to me? And really even answers regard to the first touch point being, for example, as we can see over here, the local healers, the tribal healers, the religious healers was very important for us to understand and know, so we can really help to get the best care for the patients. So what did we get? In regard to screening, as you can see over here, proudly, and this is a thanks to all of your efforts, and this is something to be very proud of, and make sure to spread the information that actually Africa does very well, rather, in regard to screening. As you can see, the average number in all 3 regions in regard to the use of alpha-fetoprotein and ultrasound is about 70%. Not bad at all, considering that we are dealing with this deadly disease, as we heard from Dr. Omar, which is like a main driver of death from cancer in the continent of Africa. Prevention, again, proudly, Africa does very well. As you can see, in regard to vaccination, it varies in regions, but no doubt it ranges between like the average of what, 80%. Average access to treatment for hepatitis B is about 70% as well. And no doubt HCV is a little bit more particular to the north, especially in Egypt. And still, however, the treatment is available up to 65% of the physician in North Africa, especially in Egypt. When it comes to diagnosis, again, acceptably okay in regard to the use of CT scans, about 60+%. However, a little bit puzzled that, and this is really varies in different directions, because biopsies are not acceptable about like 15% on the average. Even though we heard very clearly, especially, and I remember I'm talking as an oncologist, I'm talking as somebody who expertise is in advanced disease and metastatic disease. We heard from our colleague at LIRAD that who presented at ELCA lately that there's no data for the LIRAD in regard to the advanced metastatic disease, and as such, a biopsy will still be an important diagnostic tool in that regard. And the challenge, by the way, does not apply to Africa here, but apply to pretty much worldwide. In regard to staging, to be fair, this is a varied struggle also globally. Nonetheless, we can see here that the BCLC has probably the most prominence in regard to East-West Africa and North-South Africa. But at the same time, CHOP scoring is kind of like on the average about 25% used. And this is important because it applies to therapy. And you can see that there are any other of the staging system that we know has been used. And we notice that probably it's related mostly to where people were trained and whom did they acquire their knowledge from to apply the appropriate staging system accordingly. A curative therapy here only, even though it already was touched on by other colleagues, but nonetheless to show you that surgery dwindles down to the access in Central Africa with only 33%. But at the same time, we can see that we have some challenge regard to other access of therapy. And of course, still Egypt and South Africa stand out in regard to the use of transplant, with most of the cases are there while almost inexistent in other parts of Africa. Local therapy, which what Dr. Omar talked at length about, but we agreed that I will just show up here the data to kind of bit it inconsistency. Chemobilization, robustly present in North and South, about 1/3 in East-West of the physicians have access to, only 23% in regard to Central. But really the awakening call for us here that the TARE is still relatively not that accessible. And we know that the recent data showed TARE, like, certain added benefit, even though we're waiting for the final phase 3 trial results. And importantly, over here, we see that when we don't have access to local therapy, which are really the right way to go, we depend on chemotherapy, we depend on immunotherapy, we depend on tyrosine kinase inhibitors, which is a little bit kind of, a wake-up call for us about like how critical the importance of the efforts that's being done over here, because as we know, chemotherapy truly does not work in that disease. And most importantly, as you can see here, there's an important point at the last or the extreme right, you'll see that don't have access to therapy, especially local therapy, is definitely robustly present, especially in Central Africa. When it comes to first-line therapy, that's a very big and important wake-up call. Believe it or not, as you can see, sorafenib still leads the pack, even though we know very well, despite its importance and its positive results, it's still not necessarily the most kind of, driver got to the best outcome. 84%, even in North-South, where the highest GDP is, still sorafenib is the primary first line of therapy. And at the same time, despite that, only 27% of Central Africa have access to sorafenib. Then when it comes to the more novel, and this is only applicable to what's really approved already, it's in the practice, even though there are more coming based on more positive data coming out. But as you can see, lenvatinib, even in North-South, only 11%. When it comes to atezolizumab, bevacizumab, on the average, like barely 7%. And interestingly, and this is really a wake-up call for all of us, please, we urge everybody not necessarily to use doxorubicin, but you see, I'm sure we use it out of default because we don't have access to anything else. And same thing to FOLFOX, even though the FOLFOX can be further defendable based on the data that came from Arthur Chen in China, in Nanjing, comparing FOLFOX to doxorubicin showed certain relative improvement survival. But the 47% of no access or feasibility or cost in Central Africa is a very important wake-up call for all of us.
Hi, Ghassan. Ghassan, yes. This is Louis. We probably have maybe one more minute, so if you could wrap up.
So second line, very clearly here, I would say that the map is all over the place, as you can see over here. And this is something to really think about even further, because everything seems to be accessible. With this said, next step, I think we're going to just consider that this is still, there's a access bias over here that we need to look on, especially we need to continue open discussion and engage our governmental bodies. There's a issue of really, we noticed that there's a access issue in regard to the high value of training in some areas and continued broadcasted low value access in others. And interestingly, and the important thing that we noticed, there's only in all that exercise from 500 of our colleagues, only one person provided supportive care to their patients. So with this said, I stop here, pass it back to the chair. Thank you very much for listening.
Thanks so much, Ghassan.